Thanks, Steph. So Paul and I are presenting today just on the Prompt Response Network, where we're up to today and what's been happening in the last year. So I'll give a very brief run through the Prompt Response Network and leave most of the floor to Paul, I hope. So for people that aren't aware of emerging early warning systems, there's an established global recognition now that we need to respond more promptly to emerging drugs and to new patterns of drug behaviors. In NCRED, we've been trying to support a prompt response network to coordinate an information share across the jurisdictions in Australia. So we have a national network that brings together existing and emerging early warning networks across the country with the mission to share information and knowledge for timely public health responses that reduce the harmful effects of emerging drugs. So a key component in that work is the Know Community, which we launched in December of last year, slowly just to get things going. And that's been going for nearly a year now. So we thought it's a good time to think about what's been happening in the last year. The Know Community itself is a digital professional online platform that has republishes drug alerts to a live feed, as well as other reports and information of interest to people that are working in in areas either directly or associated with emerging drugs and drug trends. We have 186 people on the platform as it currently stands. That little image on the right just shows the spread that we have geographically of it. So pleasingly, every state and jurisdiction is represented, and just on the right there you can see the different sectors that are involved. And it's about, the numbers are hard to kind of tabulate just because they're in this sector, there's a lot of people wearing two or more hats, but we've got about an equal spread between harm reduction services, clinical services, toxicology, health, and other government departments and researchers, which is a great mix of people to have. And especially when we think about how we get those sectors to work together with different types of knowledge, it will be, the next phase of it will be really key in terms of capitalizing in on that. I did just want to talk briefly about what the drug alert space has looked like in the last year, and it really has been the year of nitazene. So we've had 11 drug alerts go out across Australia from the jurisdictions that publish drug alerts. So that's New South Wales, ACT, New South Wales, ACT, Victoria, and ACT. There was also a clinical alert from Queensland, and they the first one was in June of 2022 in New South Wales, and since then we've had another 7, 2 in the last month, all about nitazenes. Especially concerning because they're not picked up by fentanyl reagent testers, and there are indications that the doses of naloxone that are required are higher and needed for a longer time, just with the very potent effect of nitazenes. There have been a couple of publications come out in the Australian perspective as well. These are 3 cases that are written up, all intentional cases of somebody wanting to use a nitazene and then needing supportive care afterwards. The message thing there is that naloxone is working there. Just the other drug alerts that went out, just to touch on them briefly, there's a couple of cathinones that went out, and also high-dose MDMA is something that's being seen a lot in New South Wales. I want to stop there to just kind of leave a space for Paul to talk about what are the kind of things that we need to be considering, given that this is the state of the field now in drug alerts. And I'll hand over to you.
Thanks, Brendan. I just want to say it's a real pleasure to be here on Kaurna country. I haven't been here for about 15 years. I want to thank Uncle Frank for his wonderful welcome to country earlier today. And I want to pay proper respects to the traditional owners and custodians of this land and to elders past and present. Okay, Brendan said he's going to leave time for me, and I haven't even prepared a slide, so it's going to have to wing it here. I am here from Peer-Based Harm Reduction WA. We're a peer-based drug user organisation, but we're primarily a service delivery agency. We're the largest needle and syringe program in Western Australia. We supply more than a third of the needles, more than 2 million syringes a year through our service. We're also the largest provider of take-home naloxone. We distribute anywhere between 120 and 150 naloxone kits every month at the moment. We have sites in Perth and Bunbury. We have co-located health clinics that provide testing and treatment for BBVs and STIs. That health team's headed by a nurse practitioner, so we can do everything in-house. We don't have to refer people elsewhere. And out of those fixed sites, we have outreach services that deliver needle and syringe exchange, naloxone, peer education, and the health team has outreach workers attached who are trained in phlebotomy and using rapid PCR point of care testing equipment. So we can go to people's homes with all our services. And we also have mobile vans that operate needle and syringe program and health clinics. So we have contact with a very large, the geographic area we cover contains 85% of the state's population. And we're a peer-based agency. We get invited to people's homes. And we have a really unique level of engagement with our consumers that most mainstream alcohol and drug services or health services wouldn't get. And that's actually a really useful source of intelligence. And that's sort of what I want to talk about here, is the intersection between things like the Edna Project and the Prompt Response Network and peer-based services and frontline services. And I'll give you an example from just a few weeks ago. Our Perth site sees between 50 and 70 people a day. We're open every day of the year apart from public holidays. And about 20% of the people who access that site are street present or homeless, just because of the location where it is. A few weeks ago, we had a fellow in his 50s come in. He was becoming less responsive. He certainly looked like he was showing signs of opioid overdose to me. We got him into our health clinic with the nurse practitioner. She started doing an assessment on him and he collapsed. He was lapsing in and out of consciousness, becoming less and more responsive, put him on oxygen, gave him a dose of naloxone. He was unresponsive to the initial dose of naloxone. And the nurse said to me he'd been complaining of chest pains and that he said he'd injected cocaine. He certainly did not look like someone who'd injected cocaine, but I could see the piece of paper where the nurse had started doing the assessment and I could see he'd been prescribed perindopril, which is for hypertension. So I was worried that we were having an opioid overdose and a cardiac event at the same time. So I hit that 000 button pretty quickly. While we were doing handover to paramedics on site, a young couple came in and the woman was becoming less and less responsive, looking very unwell. And the fellow with her told us that they'd just bought some cocaine off someone on the street and injected it. And again, we had an opioid overdose. So we had two people who both reported they'd been sold cocaine on the street within 20 minutes of each other, both showing signs that looked like opioid overdose. Paramedics transported one person to the hospital. My nurse practitioner and my overdose prevention project officer transported the other person to a hospital because there's a $1,200 bill for an ambulance ride in Western Australia. So we try to avoid putting people in ambulances unless we really need to. They often don't thank us for it. So straight away, I phoned Jen Smith, who's sitting down there, who works at Royal Perth Hospital and is part of the Edna team. And I emailed a couple of people, basically alerting them to the fact that there were people arriving in their emergency department right now who Edna might be interested in taking a look at. Was it an opioid overdose? I'm not actually even sure. Neither of them were responsive to naloxone. They looked like opioid overdoses. They both said they'd been sold a white powder that looked like that they were told was cocaine. And we've had cases on the Eastern Seaboard and a couple of cases in WA of people being sold white powders and being told it was cocaine or something else, and it actually being nitazines. Having said that, both of these people were opioid naive. A quite probable explanation is a street dealer who sells cocaine and heroin got his bags mixed up that day. Yeah. And if they're unresponsive to naloxone, maybe it's not even an opioid. We've got increasing amounts of novel benzodiazepines being sold. Maybe the reason they didn't respond to naloxone is that half of their sedation was actually coming from a non-opioid drug. I don't know. That's where people like the Edna team come in. Yeah. So I want to highlight that there's a chance here for these surveillance systems to become a lot more effective if you're collaborating with frontline services, because they can give intelligence in real time. Like there is someone in your ED being triaged right now who shows these characteristics. The other more nebulous bit is the anecdotal information we get. So since that event, I've been talking to colleagues in our Southwest team, and I've also been talking to the other major needle and syringe program provider in Western Australia. And we've got a number of clients reporting to us anecdotally that they've been buying white powders that have sedating effects. Yeah. So again, how does this feed into something like the prompt response network? And the issue is that that we get this anecdotal evidence, but anecdotal evidence is just anecdote. Yeah. And there's a risk that if we talk about that anecdotal evidence too much, we poison the well, because other people hear the stories and we start a rumour mill. And then when anything unusual happens, someone comes in and tells. I've already this year had to hose down stories about xylonine in our heroin supply because people had watched an American media story about that. So yeah, how do we untangle this stuff? How do we get the maximum use out of this without potentially creating misinformation? Don't have an answer.
No, but fascinating discussion points. Thank you both so much. Do we have any questions among the audience for Brendan and Paul? Yep, we've got one hand up. I'll just wait for the microphone.
Hi, thank you for that. I was wondering if there was any talk of doing any needle check and drug analysis on needles, discarded needles. There was some talk in Adelaide of we're trying to get it started up, but logistics seemed pretty high.
Quite a few years ago, WA Police approached us to ask about that. We'd have issues around that just in terms of our sharpness handling practices. Like once it goes in that yellow bin, nobody touches it. But at the time that WA Police first approached us about it, it was also when they were first establishing DNA databases. And we have a really good level of engagement with our consumers, and it's because they trust us to protect their confidentiality. And we have to take even when we think their concerns are unreasonable, we have to take their concerns into consideration. We're a peer-based agency. Yeah. Ideally, I'd like us to have a drug checking service. That's a walk-in drug checking service, open as often as we're open. And then we'd know exactly what was in those street deals that were being sold as cocaine. You know, that's I was going to say that's best practice. Best practice would actually be regulated supply of a known substance. But I think that's probably a little less achievable at the moment than drug checking services. So that's my best option at the moment. Yeah.
Great. Thank you.